the 1 cubic millimeter of a conjunctiva, we get around 5,000 of a mast cells. So that much of mast cells, conjunctiva is rich in a mast cells, and because of the presence of the mast cells, we get an hyperimmune response and allergic response of the eye, causing an allergic conjunctivitis. So these are the organs can involve in an allergic diseases. Whichever organ has a presence of the mast cells, it can react in a allergic diseases such as the allergic rhinitis or the gut or asthma and the skin also. Likewise, eye is also rich in a mast cell. That's why eye can involve in an allergic disease. So it has been seen that around 93% of allergic conjunctivitis patients from the United Kingdom has a manifestation of atopic diseases. It can be an asthma, eczema, hay fever. So allergic conjunctivitis more sometimes may or may not, but 93% of the patients have an other atopic diseases associated with allergic conjunctivitis. According to the World Allergy Organization, WHO, around we should examine every allergic rhinitis patients because in these patients, some sites, allergic conjunctivitis signs are always, or we can see the hidden signs of the allergic conjunctivitis. So these patients always should undergo the ocular examination by an ophthalmologist or a slit lamp examination. They can have a mild, moderate, or a severe allergic conjunctivitis along with the rhinitis. Patient may ignore these itching or redness. The patient may focus mostly more on the allergic rhinitis, but they have an presence of an allergic conjunctivitis along with the rhinitis. So why it is so? There is an anatomical connection between an conjunctiva and nose. So there is a physical connection via the nasolacrimal duct. Secondly, eye is richly innervated by the parasympathetic nerve, and that enters the eyes after traveling in conjunction with the parasympathetic input to the nasal cavity. So along with an anatomical connection, nerve supply and blood supply, these are also common in the eye and nose. So whenever there is a rhinitis, we can get an allergic conjunctivitis along with it. So there are few myths about the allergic conjunctivitis. So what are those? This is in short-term diseases, but which is not. This is a chronic disease as an asthma or allergic skin diseases. It affects only childhood diseases. We used to say, or we used to hear from our professors or our teachers that as child will grow up, this allergic conjunctivitis will go down. But that is not the truth. Not many patients are carrying these disease in adulthood also. So this is also one myth. Third is it is just an itchy and red eye. No. So this disease can cause serious complications which can be blinding also, such as the keratoconus or ulcer leading to a secondary infection or the medicine-induced complications also. So we have to treat this allergic conjunctivitis with dignity as we treat the other allergic conjunctivitis like an asthma and other diseases, because we can imagine how blindness can affect anyone's life. This is what I was talking about. This is a physical connection between an eye and nose. This is a nasolacrimal duct with the terminate. This is same mucosa which is the nose and it is connected to the nasolacrimal duct. And these are the nerve inputs in the parasympathetic, how eye and nose share the nerve supply, common nerve supply. So why we should take an allergic conjunctivitis as seriously as an other allergic diseases? Because this disease is, and there is an early onset of this disease, duration is quite long, which affects the quality of life. And as there is an early onset of this disease, children suffer a lot with this, which is a growing age and schooling age. At this age, children has to study. They have to focus on their in school studies and outdoor activities also. So this disease affected that age, and it affects the quality of life, which can affect the concentration of kid, and there can be kids cannot focus on the studies because of the itching and rubbing of the eyes all the time. Then this disease is more becoming a chronic rather than seasonal. This can be a vision threatening, and because of the specifically in India, self medication with the steroids causing a medicine related complication in allergic conjunctivitis patients, which is steroid induced glaucoma and steroid induced cataract. So cataract we can treat by surgery or by implanting artificial intraocular lens, but glaucoma, which is not reversible. So in that, because of the repeated use of steroids, there is an increase in intraocular pressure, and that causes a damage to the optic nerve, which gradually reduce our peripheral vision, and ultimately patient can lose a central vision. So why it is important is because glaucoma is non-reversible disease. Whatever vision has gone, it's gone. So this is a serious thing. We should make aware about the side effects of the steroid whenever you are prescribing the steroids. And steroids, always it should be under monitored by an ophthalmologist, because whenever you give steroid, we should check an intraocular pressure. Unless and until you check the intraocular pressure, you will not come to know who is steroid responder and who is going to go in a steroid induced complications like a steroid induced glaucoma. And it has been seen that children who has an allergic conjunctivitis in their childhood, later 40% of these patients can go in an asthma. So allergic march, if patient can overcome the symptoms of the allergic conjunctivitis, but later on, because of the allergic march, there is an involvement of other organs. So if we control this disease at an early stage by a root cause management, we can stop the allergic march. So as I already told you why it is common allergic conjunctivitis, because of its anatomical position. Eye is always exposed to the environment, and like a nose, how we breathe to the nose, and it comes in a contact with the dust. Same way, our eye is always exposed to the environment and the pollution or the aeroallergens. So, because of the position, then the highly vascular structure and presence of an abundant mast cells. As I already explained, there has been around 5,000 mast cells you can see in a per cubic millimeter area of the conjunctiva. So this is why eye is more prone for the allergic conjunctivitis. So this is an classification of allergic conjunctivitis as like an allergic rhinitis. This is also in seasonal allergic conjunctivitis, perennial allergic conjunctivitis, and which according to and severity, vernal keratoconjunctivitis, atopic keratoconjunctivitis, and giant papillary conjunctivitis. Giant papillary conjunctivitis is not true atopic conjunctivitis. This is because of the trauma to the conjunctiva because of friction of the contact lenses that patient use. But VKC and AKC is the severe form of a perennial allergic conjunctivitis. Here, signs and symptoms are more or less same, but in a atopic keratoconjunctivitis, along with the ocular involvement, there is an involvement of skin also. There is an associated dermatitis or periorbital dermatitis in cases of the atopic keratoconjunctivitis, and which is more seen in a adult than the child. It doesn't mean that it is not seen in the children, but more is seen in the adult cases. So these are the signs and symptoms. We know the symptoms is mostly as other allergic diseases. Itching is the hallmark of an allergic conjunctivitis. Associated with itching, there is an redness, watering, then foreign body sensation. Patient may complain and ropey discharge, or at a morning time there is a mitis discharge. And photophobia, because of the corneal involvement, patient can get an photophobia. What is meant by photophobia is intolerance of light, and because of the constant rubbing or itching, patient can complain of a drooping of the eyelid. So symptoms, signs are mainly seen under microscope, that is a slit lamp examination. So what signs we get in allergic conjunctivitis is in papillae. It can be limbal, it can be tarsal. So anatomically, we can divide an allergic conjunctivitis into a tarsal allergic conjunctivitis and limbal allergic conjunctivitis are mixed. In some patient, we can get a both form of an conjunctivitis. Then Horner plantar spots, perilimbal pigmentation, corneal epitheliopathy because of constant rubbing of an eye, and secondly because of the tarsal papilla, that lid always with every blink it causes some trauma to the corneal epithelium, leading to an corneal epitheliopathy or pseudoxanthitoxin. This is an lipid deposits at the peripheral part of the cornea. And then the complications of allergic conjunctivitis you can see under the slit lamp, such as a Shields ulcer. That is again because of the constant rubbing of a giant papillae. It causes the erosion of an epithelium, later on forming an ulcer. Then limbal stem cell deficiency because of the chronic inflammation that limbal cells are uh, get deficient with, and patient can land up in a corneal opacity or complications. Then keratoconus. Keratoconus is here the shape of cornea gets changed, which rather than a globular, it becomes a conical shape and it leads to an irregular astigmatism. In a severe form of keratoconus, we can see a seal also because of the rupture of the descending membrane. Then complications related to treatment. Allergic conjunctivitis, along with the other signs, we can get an cataract also because of the steroid-induced complications. Then we can get an optic nerve changes of a glaucoma also. So we can get in complication-related signs also under the slit lamp. This is how they will look like. You can see these other Harnott-Randall spots along with the limbal. 360-degree, there is an interesting appearance of a limbus, and these are the and papillae or the tarsal. This is a tarsal plate. So this is a tarsal allergic conjunctivitis. This is a limbal, and we can get a mixed allergic conjunctivitis also. This is how they look like under the slit lamp. So this is a shield ulcer because of these other giant papilla. It keeps on rubbing to the cornea. It first causes an corneal epitheliopathy, and later on it can form a shield ulcer. So this is a complication of allergic conjunctivitis. So these are the signs of an allergic conjunctivitis. There you can get in subepithelial scarring. This is in corneal scarring because of deficiency. This is in zero which can mimic an arcus sinalis, what we get it in a older age. So other than ocular signs, you get an other signs also, like in other allergic diseases, such as lower eyelid edema because of the metastasis, blackening of an eye. There is an Darien's line that is in horizontal crease above the tip of the nose because of the constant or allergic salute. Then Denier's line, it causes the creases in a lower lid that occurs because of the Muller's muscle spasm. Allergic long eyelashes can be one of the sign of an allergic conjunctivitis. Then this I have already explained because of the allergic salute, we can get a Darien line out. Or open mouth breathing or between snoring. These can be associated with an allergic conjunctivitis. So we all are aware about this. Nose is an antenna of any allergic diseases. This is how this allergen are get deposited at the turbinates and which causes the further allergic inflammation. This is a cobblestone appearance of a throat we can get. So this is a blackish bluish discoloration under the lower eyelid, which is termed as an allergic shingles. This is called by the venestasis. So this is an allergic conjunctivitis classification from grade 0 to grade 5. It involves the symptoms as well as the presence of an other signs That means involvement of conjunctiva, involvement of uh, cornea, and involvement of the frontal's dots. So this it divides in from the 0 to 5 grades. So in a 5 grade is a severe grade. In a 0, everything is absent from the symptom to the involvement of conjunctiva. In a grade 1, there is then symptoms are mild and intermittent. Sometimes that can be itching or redness. There is a mild conjunctival hyperemia, and conjunctival secretions can be a minimal or it would be there. Then papillary reaction is mild to moderate, and frontal spot will be absent, and there will be a no corneal involvement. You cannot say cornea is absolutely pure and no efficacy. Then the grade 2 and grade. In a grade 2, we can have a moderate, intermediate, and moderate persistence according to the persistence of the symptoms and size. In most severe is in grade 5. There is an patient complaints throughout the year, there itching and redness, and there is an moderate to severe conjunctival congestion, and along with that, there are the tarsal papillae are the or giant cell papillae, you can say like the tarsal conjunctiva. Along with that, there is an involvement of cornea in the form of SPKs or the ulcer. So this is how we can make a chart about the presence of symptoms. These are the signs, and we can read the allergic conjunctivitis in a mild, moderate, moderate intermittent, moderate persistent, then severe and blinding stage of disease. So what should be the aim of the treatment? Aim of the treatment should be we should make a patient first comfortable and then improve the quality of life by reducing the itching, watering of these patients. Then we should aim to prevent these patients to go in a stage of the complications. So complications again, disease related complications and medicine induced complications. Disease induced complications, that means corneal epitheliopathy or Shields ulcer or keratoconus or this limbal cells deficiency leading to a corneal opacification. So we should aim to prevent the patient to go in a complicated stage, and also we should aim to prevent the medicine-induced complication to happen in these patients, such as the steroid-induced glaucoma and steroid-induced cataract. And most importantly, we should aim to stop the allergic march. As I already explained, 40% of the children who has an allergic conjunctivitis can later on go in a asthma. It has been the study has been done on these patients, and it has been proven if we don't control the allergy at that, these patients can progress and they can go it in another involvement of the other organs. That is, we should aim for this, stop the allergic match. So how we should make the patient comfortable is topical. It has to be managed systemically as well as topically. Systemically, we should control the inflammation by giving a mast cells stabilizer, or depending upon the severity of disease, we can use and monoclonal antibodies. These are the target therapies to reduce the inflammation. So depending upon the severity, we can choose whether the oral anti-inflammatory, or sometimes along with that, we need to give an biologics also. Topically, for a few days, we need to give an steroid to control the inflammation, and then later on we can start and disease modifying drugs such as the tacrolimus or the cyclosporin in 0.05 or 0.1% BID doses, and along with that we need to give an topical mast cell stabilizer such as the sodium chromolacate or olopatadine. We can prescribe along with that. And most importantly, if there is a corneal involvement, we should give a lubricating drops to keep the cornea moist and keep the cornea healthy. So we need to manage allergy at a both level, systemic level as well as topical level. Systemic level, along we can give an anti-inflammatory, depending upon the severity. Then to prevent the allergic march, we should identify the allergen, which allergens are causing the allergy, and patient is becoming symptomatic. And after finding the allergy, we can advise patient to how can we avoid allergens. Few of allergen we can avoid by advising them, such as if they are allergic to cat or dog epithelial layer, then we advise them to remove the pet from their house. Then in some patient we advise the regular pest control to reduce the cockroaches. And if patient is allergic to fungus, then we should stop, or we should stop the leakage wherever if there is a leakage or if fungus is growing in their toilets or the kitchen sink, then we can give certain tips to avoid such allergen or the allergen avoidance. But all the allergens we cannot avoid. So in such patient, then we can advise them for the desensitization. So desensitization is very important. It prevents the further progress of disease. It prevents the further sensitization of the allergens, and we can control the disease allergy in a much better way. So this is how we can stop the allergic march by detecting the allergen, by avoiding it, and by desensitizing it. This is what allergic march I was talking about, involvement of one by other organ step by step. If we don't control allergy at a root level, then one by one, other organs can also get involved. So, as I already explained, we need to manage allergy at a multiple level. First is control of an inflammation, then find out the causative allergen, and then the preventing inflammation by increasing the tolerance or by desensitizing or by giving a immunotherapy to these patients. So this is all about allergic conjunctivitis in short. So thank you very much for the patiently listening, and thank you for this opportunity.